Hey guys, this is Miss Buck. I'm going to be covering your hemodynamic monitoring part 1, and I believe Mr. Harmon will have part 2. Just make sure that you guys watch both recordings before class on Monday, and when you come to class, we'll have some activities, and you guys can ask any questions, and we'll go over everything at high points then. Okay, so what is hemodynamic monitoring? Oops, sorry. So hemodynamic monitoring is basically just our way of monitoring our body's circulation of blood and how well our cardiovascular system is functioning. The goal is to optimize oxygen delivery through accurately assessing the patient's tissue perfusion. And this can be done, sorry, there's a little bit of a typo. So this can be done by monitoring the physiologic relationship between different variables to see if oxygen delivery is adequate in meeting the demands of our tissues and our organs. And this can be done through invasive or non-invasive measures. We're going to talk a lot more about this as we kind of get into everything, but that's just kind of a rundown of what hemodynamic monitoring is. Okay, so a quick A&P review. Okay, so obviously we have our heart. It's responsible for pumping oxygenated blood out to our body through our arteries and receiving that deoxygenated blood back through the veins. It has 4 chambers. We've got 2 AV valves, the tricuspid and the mitral. These AV valves open during that ventricular diastole, and that allows blood to flow from the atria and into our ventricles. And then at the end of diastole, those atria contract, and it forces that blood that is still in the ventricles out. So as those ventricles contract during systole, the AV valves open, and the semilunar valves, which are our pulmonic and our aortic valves, open and lets blood flow into the pulmonary and systemic vasculature. And at the end of the ventricular systole, the semilunar valves close, and then the cycle starts all over. We then move on to our arteries, which are high pressure, low volume, high resistance circuits that are responsible for delivering oxygen and nutrient-rich blood to the capillary system. So our arteries are elastic, and the elasticity of these vessels is what allows them to expand to accommodate volume changes that result with the contraction and the relaxation of our heart. They have the ability to either dilate or constrict depending on what our body's metabolic demands are. We then move on to capillaries, and those receive metabolic waste and carbon dioxide from our tissues and begin the process of returning that deoxygenated blood to the venous portion of the cardiovascular system. So these are exchange vessels that are composed of low pressure, thin-walled microscopic vessels that allow for easy passage of hormones, nutrients, and oxygen to the target tissues. Then we have our veins, which are high capacity, low resistance vessels, and these hold most of our body's circulating blood, approximately 70%. So our veins contain one-way valves, and that is what keeps deoxygenated blood from flowing backwards. It keeps it flowing towards the heart so that it can get reoxygenated and sent back out to the body. Veins also have the ability to dilate or constrict depending on metabolic needs, which can either increase or decrease venous return, and we'll talk about that piece here in just a little bit. Venous return is influenced by several factors. It is influenced by muscle contraction, breathing, venous compliance, and gravity. And then last but not least, we have our blood. So our blood makes up about 7% of our body weight, which is approximately 5 liters. The more viscous blood is, the greater turbulence of blood flow that happens, and that results in a reduction in the flow in the microcirculation. So with blood, we have plasma that makes up about 60% of that blood volume, and then the remaining 40% is made up of those red blood cells, white blood cells, and platelets. So obviously we know that our red blood cells are essential for oxygen delivery to tissues because we have hemoglobin that transports oxygen out through our body. So a reduction or an increase in oxygen delivery also directly affects our hemodynamic responses in our body. Okay. So I'm going to hit on, I think you say it, I don't know that I really am saying this right, but Poiseuille's law. Anywho, Pease law. We'll just say Pease law. Okay, so Pease law states the rate of fluid through a vessel is determined by the pressure difference between the toe ends of the vessel and the resistance within the lumen. So essentially, for fluid to be able to flow in a circuit, there must be a difference in pressures in the circuit. Okay, so in our cardiovascular system, the driving pressure is generated by that contractile force of our heart, which causes a continuous drop in pressure from, sorry, that's another typo, from the left ventricle to the tissues, and then it further reduces pressure from the tissue bed to the right atrium. So no flow would occur without these types of pressure gradients. And this isn't going to be on you guys' exam, it's just kind of a basic rundown, the A&P review, and this just to have a good understanding as we get into things so that things kind of make a little bit more sense. Okay, so these are just some terminology, and we're going to talk about all of these. It's going to make more sense as we get going. I know I keep saying that, but it will, I promise. So we've got MAP, which is mean arterial pressure, and some of these you guys may be familiar with and have already had or been exposed to a little bit. We have central venous pressure, or CVP. We have preload and afterload, stroke volume, contractility, cardiac output, and then obviously cardiac index. Okay, so first we're going to talk about MAP. So you're going to see some equations, such as here. MAP equals SVP is systolic blood pressure, and then DBP is diastolic blood pressure. So systolic blood pressure right here, and then diastolic blood pressure right here. So you're going to see a couple of different equations, and you guys are going to need to memorize those. So our MAP is our systolic blood pressure plus our diastolic blood pressure multiplied by 2. So multiply your diastolic blood pressure and add it to your systolic blood pressure, and then divide it by 3. So for example, say we have a blood pressure of 120/60. So 60 is our diastolic. We're going to multiply that by 2, and that is going to give us 120. So 120 was our top number, so our systolic, and then our diastolic is also, diastolic times 2 is also 120. So 120 and 120 is 240. So then we divide 240 by 3, and we get 80. So our MAP would be 80. A normal range for our MAP is 70 to 80 millimeters of mercury, and this is the clinical parameter that we most often use to assess perfusion. So basically, if our MAP is really low and we're not getting good blood flow to things, we start seeing things like kidney failure, we start seeing multiple systemic things that start to happen that causes our body to shut down. We start shunting blood when we go into things like shock, just because our body's trying to keep our vital organs alive, like our heart and our brain, because we have to have both of those to be able to live. But in turn, other things start to deteriorate and start to drop. So when we see drops in MAP, that means we aren't perfusing. So if you have a patient with a MAP of less than 70, they're probably not perfusing as well as they need to be. I will say from an ICU standpoint, we do not want MAPs less than 60. 60 to 65 is usually our goal. And you will see things like our pressors, like Levophed, vasopressin, neosynephrine, things like that. When we start putting patients on pressors, we titrate those to an end MAP goal. So meaning we want our MAP to be 60, 65 or greater. Titrate the pressor to a goal of a MAP of 60 or 65 or greater. Okay. So next we're going to talk about central venous pressure, or CVP. So CVP is the pressure created by volume in the right side of the heart. So when the tricuspid valve is open, the CVP reflects filling pressures in the right ventricle. Clinically, the CVP is used as a guide to overall fluid balance. Normal range is 2 to 5 millimeters of mercury, and this can be monitored using a central venous line or a PA catheter and using the distal port on the end of that. You have to have some kind of central line or something that had like a PA catheter, something that will hook into like the monitor so that you can monitor that CVP pressure. It's not something you can just do manually. All right. So preload and afterload. So preload is obviously that volume of blood in the ventricles at the end of diastole. It's that end diastolic pressure. And afterload is that resistance that is left, or resistance of the left ventricle that it must overcome to circulate blood. So with preload, we see an increased preload in patients who maybe have hypervolemia or a regurgitation of cardiac valves or heart failure. We get that that backup of blood that we can't get rid of. Especially with heart failure patients. It's overloaded. Afterload, we see an increased afterload in things like hypertension and vasoconstriction. So an increased afterload equals an increased cardiac workload. So preload, we often equate to like our CVP. And then afterload, we equate it to our SVR, or our systemic vascular resistance. And we're going to talk about that in a minute. So preload is commonly referred to as like filling pressures. These pressures, or pressure numbers, include our pulmonary artery diastolic pressures, or PADP, and our PAOP, or our wedge pressures, which measure the preload in the left side of the heart, and then CVP, which measures preload in the right side of the heart. Afterload is defined as that pressure the ventricle generates to overcome the resistance to ejection created by the arteries and the arterioles. And the technical name for afterload, like I said a minute ago, is SVR, or that systemic vascular resistance. Okay, so SVR. Systemic vascular resistance represents, once again, the resistance against which the left ventricle must pump to eject its volume. So normal is 800 to 1,200 millimeters of mercury. And as our SVR increases, our cardiac output decreases. So think about that. Let's go back to the slide. So we have an increase in afterload, right? Or SVR. So we have an increase in afterload, which is going to in turn increase that cardiac workload. So we have an increase in SVR, or an increase in afterload, an increase cardiac workload, and then we're going to see our cardiac output decrease. Our heart is having to work harder, so the output is not going to be as great. Does that make sense? If our heart's having to work harder and our SVR is representing the resistance against which the left ventricle, okay, has to pump to eject its volume. So let's think back to anatomy and physiology real quick, okay? So our left ventricle is going to pump blood to that aortic valve, or it's going to pump oxygen-rich blood, I should say, to the aortic valve, which is going to in turn pump blood to the aorta, and then the aorta is going to send that blood through the rest of the body. Because remember, the aorta is our main artery that takes all of our oxygen-rich blood out and about to the rest of us. So, if we are having a hard time getting that blood through the left ventricle, okay, we can see where that's going to make our cardiac output be decreased, right? Okay. And we're going to talk about cardiac output here in just a minute, so if it's not making sense, hold with me, and I think it will. Okay. I always like to use this little analogy. So, straw analogy. So you have a high SVR that decreases cardiac output by the same mechanism that makes a small straw difficult to blow through. Afterload reduces and decreases SVR, which is represented by this larger drinking straw, which increases the cardiac output. So in other words, increasing the size of the straw enables me to blow more forcefully, and now I can shoot a spitball clear across the room. So I see she's teaching hemodynamics again. Anyway, so straw analogy. We got a really small straw. It's really, really, really hard to blow through, okay? Got a big straw. We can blow a spitball, I guess, in this case, across the room a little bit easier. All right, so next we're going to talk about stroke volume real quick. So stroke volume is the amount of blood ejected by the ventricle with each heartbeat, and this is expressed in mils. So normal stroke volume range is 60 to 70, and then hemodynamic monitoring systems calculate SB by dividing cardiac output and heart rate and multiplying it by 1,000. So cardiac output divided by heart rate times 1,000 is your stroke volume, and 60 to 70 is your normal. So stroke volume can be affected by preload, afterload, and then the contractility of the heart. Slow heart rates can result in a decreased cardiac output. And if we think about that, that kind of makes sense, right? We got a slow heart rate, we're not pumping out as much blood. Particularly with this, if the body can't compensate with an increase in stroke volume, and we have a low heart rate, it's going to cause that decreased cardiac output. Fast heart rates result in less diastolic time, okay? And this can result in poor ventricular filling. So in addition, the coronary arteries fill during diastole, and then fast heart rates can result in that decreased coronary artery filling. The degree of stretch of our heart is directly affected by the amount of blood volume that is present in our ventricles at the end of diastole. So when ventricular fibers are at maximum stretch, this is when maximum cardiac output occurs. And then when we have too much end diastolic volume in the right ventricle, this can result in like a congestion of our systemic vasculature, and too much end diastolic volume in the left ventricle can cause fluid to back up on into our pulmonary vasculature. So then we start seeing things get backed up into our lungs, and we start seeing fluid on our lungs, and we just have lots of problems. So I kind of think of this as like right versus left-sided heart failure. So that right-sided heart failure is that systemic vascular. It's going to be the ankle swelling. It's going to be, a body issue. We're going to see it manifest in our bodies, in our systemic vasculature, ankles, legs, feet, all that good stuff. Left-sided heart failure is going to be what causes that pulmonary edema. So that pulmonary edema is going to cause that pink frothy sputum in these left-sided heart failure patients that we see because of the fluid backup into the pulmonary vasculature. And then when we have too little blood at end diastolic volume, this results in a reduction in cardiac output. So with this, optimizing our preload or our ventricular filling in critical care is usually a main goal, since this will help to increase blood flow and oxygen throughout our body. Okay, so contractility is simply just the heart's contractile force. It's also known as inotropy. Ino equals strength, entropy equals enhancing. It can be positive or negative. And then in critical care, you will often hear about inotropic drugs that increase the heart's contractility. So big thing I think of here is dobutamine. Dobutamine is probably the biggest one that we see in critical care. We can also see milrinone used. I've seen it used just a handful of times, but I think dobutamine is probably more cost effective and just a little bit easier to get a hold of. But they are positive inotropes. So positive inotropes are going to make the heart muscle contract stronger and raise that cardiac output to a normal level by helping increase the amount of blood that the heart pumps out. So our negative inotropes are going to be things that weaken or lower our heart rate or our like the amount of blood that our heart puts out, or our blood pressure, things like that. So I think the best example of this would be like maybe metoprolol has type of like negative inotropic effect. Anyway, negative inotropic meds are going to be things that help to decrease or weaken the pumping of the heart. Positive are going to be the ones that we usually use the most in critical care, and it's to help increase that cardiac output. Okay, so I know I've talked 5,000 circles about cardiac output, and now here we are. So cardiac output is calculated by our heart rate times our stroke volume. So heart rate times stroke volume equals cardiac output. Cardiac output is the amount of blood pumped out by a ventricle over 1 minute, and then our normal range is 4 to 6 liters per minute. So big thing here, heart rate times stroke volume is cardiac output. Normal is 4 to 6, and then cardiac output is the amount of blood that is pumped out by a ventricle over 1 minute. Okay, so cardiac index is cardiac output divided by our body surface area. So this is considered to be a little bit more accurate than cardiac output because it's individualized to someone based off of their height and weight or their BSA. So normal range is 2.2 to 4.0 liters per minute per meter squared. Okay, so this is just kind of a little diagram, and I just thought it helped make a little bit more sense. So our things that are affecting our stroke volume are preload, afterload, and contractility. So remember, preload is the volume of blood in our ventricles at the end of diastole. So it's that end diastolic pressure. So this is, referred to as our filling pressures. And then afterload is the resistance that the left ventricle must overcome to circulate blood. Okay. And then contractility is just the heart's contractile force. And then those go into affect our stroke volume, okay, which is the amount of blood that is ejected by the ventricle with each heartbeat in mils. Okay. Then we have our heart rate, obviously, remember? And then we multiply those to get our cardiac output, which is the amount of blood pumped out by our ventricles over 1 minute. Okay. All right. So now I just want to take a minute and talk about the Frank-Starling curve. So basically what this is the more stretch, the stronger the contraction until a physiological limit has been reached. Okay, so according to Starling systolic performance, systolic performance is determined by diastolic function, or the preload. Okay, so the greater the fiber length or stretch during that diastole or the preload, the greater the fiber shortening and ejection during systole. Okay, think of it kind of like a rubber band. So basically, Frank and Starling identified that the relationship between the myocardial fiber length and the force of contraction found that the more the diastolic volume or fiber stretch at the end of diastole, the stronger the next contraction during systole to a physiologic limit. You can only stretch so far without breaking, okay? Remember that. Same with the rubber band. You can only pull it back so far without it busting, okay? All right. Okay, so when we monitor our cardiac output, by monitoring that and the pressures that are within our cardiac chambers, we can determine the optimum preload, or remember that filling pressure, that produces the maximum cardiac output for that particular patient. So we also have to consider afterload. So vasodilators or vasoconstrictors are used to manipulate the diameter of blood vessels, okay? And that can impact our stroke volume and therefore our cardiac output. When we have a rapid vasodilation, okay, or a decrease in blood pressure, that can decrease the preload of our heart, so slow changes should be used to help increase the cardiac output, and that will also decrease myocardial oxygen consumption. So we can see on this chart we have the ventricular stroke volume here on the side, and then our LVEDP, or our left ventricular end diastolic filling pressure, okay? So that preload and that afterload. When we see an increase in cardiac contractility, we see that LVEDP is at 12, but then that stroke work is at 125 or greater. Okay, so increased contractility is up here. When we have a normal contractility, it's a little bit lower. Then a decreased contractility, we have a lower ventricular stroke volume. Just a comparison chart, really. All right, so now I am going to talk about the hemodynamic monitoring systems. Okay, so we have bedside hemodynamic monitoring. So this is typically what we would consider invasive. So it's a measurement and interpretation of invasive hemodynamic parameters to determine cardiovascular function and regulate therapy as appropriate. So this allows us to survey the heart rate, our preload, that ventricular end diastolic volume, ventricular afterload, and ventricular contractility. So here is just like a little diagram of a patient with an invasive catheter. I know it looks like a lot. Here's our bedside monitor, and then all the cables, and then our patient, and basically the different angles of what the patient is supposed to be at. So we have 4 different components. We've got an invasive catheter and high pressure tubing that connect the patient to the transducer, which is going to be what helps read and send the stuff to the monitor. The transducer receives the physiologic signal from the catheter and the tubing, and then, like I said, it helps convert it into electrical energy and send it. Our flush system helps to maintain patency of the fluid-filled system and the catheter, and then our bedside monitor contains the amplifier with the recorder, and this increases the volume of electrical signal and displays it basically on the screen for us to see in that millimeters of mercury. Okay, so we've either got to have, there's a couple of different, and I know here this is like very vague and basic, but we're going to talk about the different types of lines and how it all goes. So we've got a couple of different ones like A lines, swan scans, catheters, or PA catheters, I think is what they're called. They're more for like your cabbage patients and stuff, and I was never a heart nurse, so I didn't deal just a ton with those. And then CVLs and A lines are the other 2. It's gonna make a little bit more sense as we get into it. Okay, so our basic setup, we've got an invasive catheter, either an A line, a CVL, or a swan scan catheter. We have high pressure tubing with transducer. We have a transducer holder. It's just a little thing that hooks onto the IV pole and that just slips down into it. We have the cable for the transducer, and then we've got a bag of saline. Saline should be the only thing that ever goes with any kind of invasive catheter, unless otherwise stated by a physician. But I have never used anything other than saline. It should be the only fluid that is ever with any of this. Then we have a pressure bag that's inflated to 300 millimeters of mercury. And then I have also attached a video down here. I'm not going to play it right now, but it's down there for you to watch. And it does a really good job of going in depth and talking about how setting up goes and everything for this. Okay. Other important factors when setting up. So we want to maintain under pressure to prevent backflow and assure continuous forward flow. So that's why we have that pressure bag of saline. It helps keep pressure, because if you have an A line or something in an artery, that it's eventually going to get blood flow backed up if you aren't keeping a positive pressure, keeping things going forward. So on your pressure bags, they'll have like a little green line indicator, and you basically pump the bag up until that green line hits, and that's supposed to be the right amount of pressure to help keep everything moving forward. Sometimes bags do lose air, and you have to redo them and give them a little bit more air. It's not a big deal. We also want to make sure we don't have any air bubbles. We know air bubbles are bad. We can trace this back to Fundies last summer when we talked about no air bubbles in anything. Air bubbles, especially in like arterial lines and CVLs and things like that, can be very detrimental to patients, especially if they're larger, because it can kill them. We also level that transducer at the phlebostatic axis. So it's the fourth intercostal space, and it's the mid-axillary line. And I've got a slide, the next slide over has like a little diagram. But you guys need to remember that. Level the transducer at the phlebostatic axis, okay? Fourth intercostal space, mid-axillary line. And then we want to zero it. So by zeroing our CVL, A-line, all of that good stuff, if it's connected to something, it eliminates the effect of atmospheric pressure, okay? So it basically takes out that atmospheric pressure and gives us what we need to know. And then we want to calibrate it. There's just a way to calibrate and set it up on the monitor, and every monitor is a little bit different. When you guys do ICU rotations this summer, we can look at that. And sometimes if you're in like an OR or something, if you ever go down with the patient and you're ever in the OR, hit up your CRNA, because they are the bomb diggity at these type of things. Like, this is what they do. They maintain your airway, but they also monitor literally all of your hemodynamics, and they can probably explain this 10 times better than I ever could. So if you're ever, with a patient and they go down for a procedure, and the CRNA has some time, hit them up, because they are ICU nurses at baseline. That is their backstory, and a lot of them do have a history of cardiac patients. They were heart nurses at some point. And they're just very, very, very educated on all of that. So there's just my little tidbit. Hit them up, utilize them. They're wonderful. If we, going back to the phlebostatic axis thing for 0.5 seconds, the problem is if we have this too low, if that transducer is too low from that line, then we can have a falsely high reading. And if it's too high, we can have a falsely low reading. So it's the opposite. Too low is too high of a reading. Too high is too low of a reading, or it can be a falsely low reading. So think of it in reverse. Too high equals too low. Too low equals too high. I know it's backwards, but anyway. That's why it's important to always make sure it's at that spot. Okay. And so this is that phlebostatic axis like I was talking about. So fourth intercostal space at the sternal border to the right of the chest, okay, is A. So right here is that fourth intercostal space. So then we draw a little imaginary line. So then we draw an imaginary line with our B line here, and it is drawn at the level of the midpoint between the anterior and posterior surfaces of the chest, okay? So basically, right here in the middle where they meet is that fourth intercostal space, mid-axillary line, phlebostatic axis. Okay. So if the patient is hemodynamically stable, raising the head of the bed does not affect pressure measurements. Patients do not have to be flat to monitor hemodynamic pressures, okay? Measurements can be recorded in a non-supine position, but if adjustments are made, adjustments must be made for the position of the transducer. So if you move your patient, that transducer's got to be moved, okay? So if we've got a patient on a vent with an A-line, what do we not want? We don't want, well, I don't think you guys have had mechanical ventilation yet, because I think I teach you that in a couple of weeks. So anyway, if we have a patient on a vent, we don't want them flat, okay? Because that can increase their risk of developing pneumonia. It can increase their risk of aspiration. There's just a lot of things that can factor into that. And we'll talk about that in a couple weeks. But we typically don't want them flat, right? So we want them at least head of bed 30 degrees or higher, okay? But if we raise them any higher or put them down flat for whatever reason, we have to move that transducer for that invasive hemodynamic line when we move the patient. Otherwise, it is not accurate. It's got to be moved, re-zeroed, and recalibrated to ensure that it's accurate. On the flip side of that, if we have a patient that is hemodynamically unstable, or if they're hypovolemic, so they don't have, they're dehydrated, or they're just fluid volume deficit, whatever, they're hypovolemic. Raising the head of the bed can actually negatively affect that intravascular volume distribution, and they need to be returned to a flat position. So head of bed is most accurate with these lines when it is 0 to 60 degrees. So like I said earlier, typically with vent patients, we want them at about a 30 degree head of bed, 30 to 45 degree head of bed. And that's most of the time what you will see. But if a patient is hemodynamically unstable, if we set them up too far in the bed, it can negatively affect that intravascular volume distribution, and we'll probably have to put them back down flat to help re-level things back out. But remember, anytime you move your patient, the transducer has to be moved to the fourth intercostal space, that phlebostatic axis. Patient moves, transducer moves. Otherwise, it ain't accurate. And your patient could be reading an arterial blood pressure of 112/70, and it's really 60/30, and your patient's fixing to crash and you don't know. All right, arterial lines. So these are pretty much self-explanatory to a certain degree. They're arterial lines. They are placed into an artery, most often the radial artery, but they can also be put in your femoral artery. Sometimes if a patient is extremely shunted, like if they're compensating and they're just vasoconstricted to all get out, to kingdom come, sometimes you can't get a radial arterial line on them, just because everything is shunted and their pulses are like basically non-existent in their extremities. So sometimes FEMs are our only option. They're not as ideal just because they sit right in the crease of your, like where your leg and your hip meet. And so it's just, sometimes they get kinked. The infection risk is a lot higher just because it's in your groin. So there's just a lot of things that if we cannot do a FEM, we really try not to. But if necessary and we can't get a radial, obviously we can. We can also, I've never seen them done in brachials. You can also put them in brachial arteries. And then I think there's also like your dorsalis pedis, they can do a pedal artery. I've also never seen that. But with the flip side of that, I've also never done pediatrics. So pediatrics may be a completely different ballgame and their location on things. So I'm just speaking for like the general adult world. We typically see these put in radial arteries. The major advantage of the radial artery, of putting it there, is the supply of collateral circulation to the hand provided by our ulnar artery. So to test, we have to perform what we call an Allen test whenever we go to put a arterial line in. And you will never be placing an arterial line as a nurse. It will always be a provider. And honestly, even with like ABGs, like with arterial blood gas sticks, respiratory has been, I as the nurse have never had to draw that. Not saying that you can't, but respiratory is the one who draws that. So a lot of the times you will see them perform the Allen test. I know I see respiratory do this a lot. I don't really know, I guess, necessarily about having seen it done from a provider standpoint, but it's also usually been in like pretty critical situations and we're just trying to get a line in them to get a pressure. Sometimes things are just a little bit more hectic and they may be doing it and I just not know. So our radial and ulnar arteries when we do an Allen test are both compressed simultaneously, okay? So the patient, if they can, is asked to clench and unclench their hands until it blanches. So one of the arteries is released and then your hand should immediately flush from that side, okay? And then it's performed basically by completely obstructing the blood flow to the hand since we compress the radial and the ulnar arteries for a minute or two. And if adequate collateral blood flow exists, there will be a rapid return of color to the hand upon the release of the ulnar artery. So basically, we compress both of them, have them clench and unclench their fists, and then if they have good collateral blood flow, meaning that their blood flow returns back like immediately, when we release those arteries, it'll pink right back up. The color will come right back. So when we compress them, we're kinking off that blood flow, so their hands probably can get real pale. And then as soon as we release it, boom, and it comes back. It's like, okay, they got good collateral flow. Like, we're okay to put an A-line in here. So as you can see, there's a little pressure bag here. And they have the little transducer with the flushing system. The arterial line goes here, and it's connected to the saline tubing, and then the transducer is connected to the monitor. So with A-lines, the nice thing about them is you can draw arterial gases from here directly. So there's usually like a little stopcock on the arterial lines, and you can basically like there's a way to like turn the stopcock and then you can draw blood out of it. It's a lot easier to explain this in person. I have a way more difficult time trying to explain things than I do just showing them, like showing you guys how to do it. I'll try to find a video and on some of this stuff I'm just a very visual person and like a monkey see, monkey do kind of girl. But I'll try to find a video on this stuff, or you can even try to look it up on YouTube and whatnot too. But basically, if you have an A-line, you can get lab draws, you can get ABGs, and you don't have to actually stick your patient. And you never have to actually open the system. So this is a closed circuit, obviously. But meaning with this, you would scrub your hub with CHG or alcohol for 15 to 30 seconds. 15 if it's CHG, 30 if it's alcohol. And then you just connect a syringe to it. And even some of these lines have like a little waste tube when you pull back to get blood. It wastes 10 cc's in the tubing, and then you just pull back from there like after that, and then you're good. So it is kind of nice, but not every patient in critical care has these. So they are very invasive and an infection risk, and if we don't have to have them, obviously we don't. Okay, so why would we need an A-line? So obviously if our patient is very hemodynamically unstable, if your patient is on vasopressors, you absolutely have to have a way to get a blood pressure. And if you stop being able to get blood pressures in your arm, your leg, whatever with a cuff, an A-line is your next step. It's an arterial blood pressure, and it's the most accurate. Patients who require frequent BP measurements. So again, like I was just saying, if you got a patient on vasopressors, things that you have to know what their blood pressures are because you're titrating your vasopressors to a MAP endpoint. Obviously, we got to know what our pressure is to be able to get our MAP. And then if we need accurate information due to a low flow state, same with what I was just saying with pressors. Basically, everything that I'm talking about at the moment goes back to pressors. If your patient's on pressors and you can't get a blood pressure, we're going to have an A-line. And then the need for frequent arterial sampling. Sometimes people who are really acidotic or alkalotic, your DKA patients, people like that, who get frequent ABGs, or if their pHs and stuff are off, or if they're super, super, super sick, septic, whatever the case may be, sometimes they'll put A-lines in them if they do need frequent arterial sticks and their pressure is not great. Most of the time, if they're needing frequent arterial sticks, their pressure is probably not going to be the best anyway, and they may even be on pressors, and so they're probably going to have an A-line. So these are indicated for any major medical or surgical condition that compromises our cardiac output, our tissue perfusion, or our fluid volume status. And like I said earlier, it provides continuous measurement of our systolic, our diastolic, and our MAP. It must be monitored closely, such as our blood pressure must be monitored closely, like I was saying a minute ago, just as like when we have shock patients, major surgery, hypertensive emergencies, or vasopressor therapy. And this is particularly true if the blood pressure abnormality is acute or the blood pressure is very labile. Okay, so this slide shows the appearance of the waveform of an arterial pulse. So number 4 is the anacrotic limb that represents the first phase of the arterial pulse. It occurs as the ventricle ejects blood into the artery, and it records the arterial pressure rising. Number 1 measures the peak pressure on arteries during systole. It's the dicrotic notch, and it follows this force, or following this force, is decreased and pressure drops. Number 2 is I definitely said number 2 was number 1 was the dicrotic notch, and I just looked at the slide wrong. Number 1 is the peak systolic pressure. I'm so sorry. Number 2 is the dicrotic notch. I didn't think that made sense when I was saying it, but I just was going with it, and I was like, I still don't think that's right because it's not. So number 4 is the anacrotic limb. Number 1 is the peak systolic pressure. Number 2 is the dicrotic notch, and the dicrotic notch is the pressure in the ventricle that falls below the pressure in the aorta. When the aortic valve closes, the notch is produced by the sudden closure of the valve, and this indicates the end of ventricular systole or the beginning of diastole. And then we have number 3, which is the diastolic pressure. So as blood flows or continues to flow to the periphery, so like our hands and our feet, the pressure in the arterial system continues to fall, and the lowest point of the waveform is the diastolic pressure. You guys do need to know what each of these are and what they do. Okay, and this is just another little, I thought it kind of highlighted really well. You know, we have our map here. The dicrotic notch is the closure of the aortic valve. And then total area under the curve is our map. So we've got systole and then diastole. And then this is our heart rate right here. And then this is the blood pressure, arterial pressure. Okay. So this is a simultaneous, kind of like on the previous slide. This is like your ECG, your heart rate, and then this is your A-line waveform. So this is a simultaneous ECG and a normal pressure or arterial pressure tracing. So as you can see on the ECG tracing, the QRS complex, so right here, occurs prior to the increase in the arterial pulse, okay? So consider that the QRS reflects the ventricular depolarization or the contraction, which is then followed by an increase in the arterial pressure. So as the aortic valve opens, blood is ejected from the left ventricle and is recorded as an increase of pressure in the arterial system, which then in turn, the highest point is systole. After peak ejection or systole, that force decreases and the pressure drops, and then a notch, that dicrotic notch, may be visible on the downstroke of this arterial waveform, which represents the closure of the aortic valve, okay? And then the dicrotic notch signifies the beginning of diastole. Remainder of the downstroke represents diastolic runoff of blood flow into that arterial tree, and then that lowest point recorded is that diastole. Okay, just another little ECG and arterial pressure tracing. So this pressure tracing, particularly right here on the A line, is caused by a fibrin sleeve that occludes the tip of the catheter, and it kind of kinks the catheter or tubing if that happens, or sometimes there's air bubbles in the system. We call this dampening, so it's just like a dampened waveform. It means it's not like as high as it should be. All right, so this is, I don't know why that's cut off. This is the square wave test. So we can see that this is our observed waveform. So basically this is done to make sure that the A line is calibrated and stuff like it should be. So this should be done at least once a shift. Usually like at shift change, like with the outgoing and the oncoming nurse. So to do this, remember I said earlier there's going to be saline connected to your system. So you basically flush the system. There's like a little pulley tab, and you flush it real quick. And when you flush it, you're going to see your wave happen. So like we see our little waveform here, but then all of a sudden it's going to shoot up, and while you're flushing it, it's just going to kind of flatline out up here at the top. And as soon as you release it, it's going to go back to your waveform. So when you do that, you know that it's set up correctly. All right, so nursing management of A-lines. So we want to monitor and make sure that the site is clean and maintain it clean with our dressing. Obviously, like I said earlier, this is an arterial line, so the chance of infection is high. We want to monitor the tissue distal to the catheter for decreases in tissue perfusion. If we have a line that's starting to go wonky, sometimes we'll start to see discolorations, and sometimes we have to pull them and put new ones in, especially if they've been in for a really long time. We want to use an immobilizing device if appropriate, kind of like in that picture. They have like a little wrist brace on. It basically keeps that hand flexed a little bit, like flexed back, because it keeps that radial artery open. Because if you start bending your wrist, you're going to kink that catheter, and it's not going to give you an accurate reading. We want to inspect our site frequently and be sure all ports are properly capped. Remember, very high risk infection or risk for infection, so make sure that you've got all your swab caps and all your ports and stuff closed off, clamped, capped at all times. Be sure all of your connections are appropriately tightened. Sometimes if things are loose, it won't give you an accurate reading. And then be sure high and low alarms are set appropriately. So just like with blood pressure parameters on a thing, you can set your A-line parameters to alarm at set points. So if it drops under a map of, like a lot of us in the unit, we were concerned about our maps. Okay, I get that your systolic pressure is 90, but your map is still 65. So I'm okay as long as your map doesn't fall under 60. So we would set like our parameters for our map if it dropped under 60 or 65, whatever the end point for our map was on our pressors, or to keep our map above, we would set it for that. So it would alarm, the monitor would alarm whenever our map dropped below that parameter. Okay, so removal of A-lines. So removing an A-line is super similar to like removing just a regular IV, but it's an artery, so we do have to pay a lot closer of attention to make sure that it's clotted off really well. You as a student do not remove A-lines. As a nurse, when you have a license, go for it, boo-boo. But as a student, never, ever, ever. You can be with your nurse while they are doing that, but you should not be the one removing an arterial line, ever, or really a central line for that matter. When we pull these, we have to make sure that we hold pressure for at least 5 minutes, but if we've got patients who are on, Eliquis, any kind of blood thinners, even just our little old meemaws and peepaws who bleed more, even people who are on birth control puts you at a higher risk for bleeding, or prolongs your bleeding time. So we have to make sure that we hold pressure at least for 5 minutes or until that hemostasis occurs or that clotting. And then obviously we want to frequently assess the site after removal. A lot of times we'll put like a little pressure dressing over it after it's clotted off, just to kind of keep a little bit of pressure on it and make sure that it stays clotted off real good. All right, CVLs. So we've all probably, I know a lot of you guys have seen central lines in the hospital already, especially like PICC lines and stuff. So these can be used to monitor our CVP or our right atrial pressure, that RAP, CVP or RAP. Can also be used in helping to monitor SVO2, which is really helpful with sepsis. So SVO2 is venous oxygen saturation, so it's that venous oxygen return that's bound to hemoglobin. And then central venous pressure, we've already talked about. I said earlier we can measure this with the distal port of the CVL. So CVP is important because it's used to approximate that right ventricular end diastolic pressure. Normal is between 2 and 8 millimeters of mercury. And a low CVP value typically reflects hypovolemia or a decreased venous return. A high CVP value typically reflects overhydration or like a fluid overload type situation, increased venous return, or right-sided heart failure. So fluid overload goes with the right-sided heart failure. Okay. Pulmonary artery catheters, those PA catheters, also referred to as Swan-Ganz, or sometimes you may hear them referred to as a right heart cath. You're going to see these a lot in your cabbage patients or fresh hearts or however you want to call it. Like I said earlier, I personally don't have just a ton of experience with these because I wasn't a heart nurse, but your heart nurses typically will be able to tell you anything and everything about these. Miss Fleming is a great resource, and she actually has, I think, a PA catheter. So I may get it and see if she'll let me borrow it and bring it to class on Monday just to show you guys. Okay, so these are indicated for hemodynamically unstable patients, for shock states. Personally, even with shock patients, I never really had these. Or for diagnosis and evaluation of heart disease. So we use these to help evaluate patient responses to treatment. A PA catheter can simultaneously assess that PA systolic and diastolic pressure, and then also a PA mean pressure and a PA wedge pressure. So that PA catheter also can measure cardiac output, determine mixed venous oxygen saturation, and help calculate additional hemodynamic parameters. So it can do a bunch of good things. So this is why it's really, really, really important in our post-op cabbages and stuff for us to have these, just because it gives us a plethora of information and we're able to assess so much with them. Okay, so how is it all really connected? So for hemodynamic monitoring purposes, the right and left heart are differentiated as to function, structure, and pressure generation, okay? So that pulmonary capillary bed lies between the right and left heart. And the capillary bed is a compliant system with a high capacity to sequester blood, okay? Circulatory system consists of 2 circuits in a series. We have the pulmonic circuit, which is a low pressure system with a low resistance to blood flow. And then we have the systemic circulation, which is a high pressure system with high resistance to blood flow. Basically the right side of the heart versus the left side of the heart. Okay. Alright, so this is just kind of a picture of how that PA catheter sits in the heart. So we see it's floated in through the right atrium, right ventricle, up, and then out. So it sits right here. Okay? And then that balloon is inflated right here, and that is where we get our wedge pressure from. You can see the little two lines right here. So this is the distal port in the branch of the pulmonary artery. So it sits, obviously, PA catheter, pulmonary artery. So it sits right here, floats out from the right ventricle, sits right here in the pulmonary artery in the distal portion. And that's where we get our wedge pressure from. So we can see our lungs. And then we have that static venous blood flow to the left atrium. And then we see that PA pressure, the PA wedge pressure reflects our left arterial pressure, or atrium pressure, sorry, left atrium pressure. Alright, so to insert it, there are several videos listed here. Basically, there's like an introducer. It's a clear, like, little piece. So, like right here, I know the pic's like super, super blurry. But then that PA catheter is introduced through the introducer, which is the yellow part or the horizontal piece right here in this picture. So this clear part is the introducer, and that's what keeps this sterile. Okay? Because this goes in and sits obviously in our pulmonary artery and needs to stay sterile. So it's introduced through this PA catheter, or this little yellow piece right here. This line. Introduced. And then it floats and it's in there. Highly recommend watching these videos because it's going to explain it 3,000% better than I ever could. Okay. This is just another little picture. So, like I said earlier, because of all of this, we can measure our CVP, our PA pressures, wedge pressures, our cardiac output, cardiac index, and then our SpO2s. Okay, so when we look at the right atrial waveform, this is going to be our CVP waveform. So we inflate the balloon prior to passing through the tricuspid valve, and that cushions the tip, which will cause less myocardial irritability, so fewer ventricular arrhythmias, in other words. And it assists the catheter to float with the flow of blood from the right ventricle to the pulmonary artery. The right ventricular waveform is distinctly pulsatile, so we can see that, with distinct systolic and diastolic pressures. So ventricular ectopy is very common. And that ventricular ectopy just means that there's extra beats or like PVCs, things like that occur. Then we have our pulmonary artery, that PA waveform. So we see that dicrotic notch and that visible downslope of waveform that represents the closure of the pulmonic valve. And then we have that PAOP waveform, that pulmonary artery wedge pressure waveform. And it decreases in size and is non-pulsatile. So that balloon is wedged in that small pulmonary vessel. And that's how we measure that wedge pressure. And then you can see over here on the side all the pressures. Okay, so speaking of normal pressures, or pressures in general, so pressure values. So you do need to know what the normal pressure values are. So your right atrium pressure is 2 to 6 millimeters of mercury, or 2 to 5, 2 to 5, 2 to 6. Your textbook normal values are what I'm fixing to tell you, but it varies a little bit from this image. So your textbook says your right atrium is 2 to 5 millimeters of mercury. Your right ventricle is 20 to 30 millimeters of mercury. Your pulmonary artery is 20 to 30 millimeters of mercury, and then your PA, your pulmonary artery wedge pressure, is 5 to 12 millimeters of mercury. Okay, so using the pulmonary artery systolic pressure to evaluate afterload of the right ventricle is what we're doing here. So here the PA balloon is deflated and the ventricles are in systole. So since that pulmonic valve is open, the PA systolic pressure reflects afterload of the right side of the heart, okay? And then systolic pulmonary artery pressure is used to calculate that pulmonary vascular resistance, which is the afterload of the right ventricle. Okay. So in this image, we are using the RAP and the right atrial pressure slash CVP, central venous pressure, to measure the preload of the right side of the heart. So during ventricular diastole, those pulmonic and aortic valves are closed and the mitral valve is open. So the ventricles fill passively from the atria, and then there is atrial contraction to fill them just before the valves close and systole begins again. And then we move to the diastolic pulmonary artery pressure occurs at this time. So remember that the right atrium is a low pressure atrium, or a low pressure chamber. With the valve open, pressures inside that right atria and right ventricle then equalize. So therefore, we monitor this pressure as an indication of preload or fluid status of the right side of the heart. So right atrial pressure, or CVP, equals preload of the right side of the heart. I need you to know that. This is used to guide fluid replacement, and then changes to the patient's RAP and CVP following fluid changes helps provide important information about the patient's fluid volume status. Okay? And then the volume of blood filling the left ventricle at the end of diastole represents the amount of blood available for ejection during systole. So this is known as the left ventricular end diastolic pressure, the LVEDP, which is the preload of the left side of the heart. So we can't really directly measure the volume in the left ventricle at bedside, but we can measure the pressure generated by the volume. So during ventricular diastole, when that mitral valve is open, there's essentially a clear pathway between the tip of the catheter and the left ventricle. So in the absence of pulmonary hypertension, the pressure from the tip of the catheter to the left ventricle is equal. When we use this theory, we are basically able to estimate the preload of the left ventricle, or that LVEDP, by monitoring the PA diastolic pressure or the pulmonary wedge pressure. So 2 ways to measure LVEDP with PA catheters. One is, the most accurate, is that PAWP, that PA wedge pressure, when the balloon is inflated and lodged in that pulmonary capillary, it blocks the pulmonary artery pulsation. So the only pressure the tip measures is the pressure in the atrium, which is the reflection of that left ventricular diastolic pressure. So this is how the pulmonary artery catheter is on the right side of the heart, but it can measure pressure on the left side of the heart as well. So the second is the PAD pressure. So during diastole, PAD is equal to pulmonary wedge pressure, which is equal to LVEDP. Okay, so during diastole, the pulmonic valve is closed, which negates the pressure from that right ventricle. So with the tip of that PA catheter looking forward, it reflects that pressure from the pulmonary capillary bed to the left atrium and then to the left ventricle. So pressure in that pulmonary capillary bed is low and does not have a significant impact on this reading unless the patient has a significant respiratory disease, okay? So pressure at this point between the left atrium and the left ventricle equalize when that mitral valve is open during diastole. And if significant lung disease is present, the PA pressures are super elevated, independent of that cardiac pressure. So it's not very accurate for people with lung disease. So COPDers and stuff like that. Significant mitral valve disease can also impact the PA pressures and the wedge pressures, which can prevent them from appropriately reflecting those left ventricular and diastolic pressures. Mitral valve stenosis will increase PA and pulmonary artery wedge pressures with a normal left ventricular and diastolic pressure. And then mitral regurgitation, with that, the pulmonary wedge pressures increase due to the abnormal backflow during systole because of that regurg. Okay, so we're going to put this all together. So left ventricular preload is measured using pulmonary artery diastolic pressure, or that pulmonary artery wedge pressure. Okay, so during ventricular diastole, when the mitral valve's open, there's that clear pathway between the tip of the catheter and the left ventricle. So in the absence of significant pulmonary disease or mitral disease, the PAD pressure or the PA wedge pressure reflects the left ventricular and diastolic pressure. So the PAP or PA wedge pressure equals left ventricular preload. Okay. Right ventricular preload is measured using the right atrial pressure or central venous pressure, okay? So during ventricular diastole, that tricuspid valve is open, pulmonic valve is closed. Right atrium is a low pressure chamber. With the tricuspid valve open, pressures inside that right atria and right ventricle equalize during diastole. So then we can use this number to indicate the preload or the fluid status of the right side of the heart, which is, remember that we monitor changes to the RAP or CVP during and after fluid change in boluses, okay? So this can provide us with that important information regarding that patient's fluid status. RAP and CVP, so right atrial pressure and central venous pressure, is used to evaluate preload of the right side of the heart. Beware that a PA catheter is not required to monitor CVP, okay? It can be monitored through the distal portion of a central line because that tip of the central line sits in the superior vena cava. We do this a lot with patients who are septic, their fluid volume overloaded, they have right ventricular failure, or maybe they're a cardiac tamponade kind of case. All right, so cardiac output measurement. So determines cardiac output and index for measuring the rate of blood temperature change. So thermodilution, cardiac output bolus method is intermittent. So we use 10 mils of room temp saline that is injected into the proximal lumen of the PA catheter. That injectate exits into the right atrium and then travels with the flow of blood past the thermometer, or the temp sensor, thermometer is what I always call it, located at the distal end of the PA catheter. And then that continuous cardiac output, so we have that thermal filament on the PA catheter that generates low energy heat impulses into the bloodstream. And these changes in temperature are detected by that thermometer or that thermometer and used to determine the cardiac output. So basically thermodilution has been the method used for measuring cardiac output using the PA catheter. So, like I said, we use that saline, cold or room temperature. It's injected into that right atrium port. That little thermometer tip of the catheter then measures the temperature of the blood flowing past it, and then the computer generates a time temperature curve and a result of rate of change in blood of temperature of blood that flows past it. So it makes us a little chart. And then that's what is used to determine the cardiac output. In continuous cardiac output measurement, that thermal filament on the PA catheter generates that low energy heat impulse into the bloodstream, and then those changes are detected by that thermometer and used to determine the CO. Average CO over 3 minutes is determined and updated every 30 to 60 seconds. Okay, so cardiac output. So we've got a low cardiac output. Could be from like an MI, CHF, valve disease. And then if we've got and then we've got a high cardiac output, we can, a lot of times this is caused by septic shock, increased metabolic states, septic shock again, sorry. That's definitely a typo. It just copy and pasted twice. So, septic shock and increased metabolic states. So, most common cause of decreased cardiac output is that MI, because that causes pump failure, which results in that decreased cardiac output. Things that result in inadequate filling of the heart can be tachycardia, dysrhythmias, hypovolemia, mitral stenosis, tricuspid stenosis, tamponade, and then restrictive cardiomyopathy. Things resulting in inadequate ejection can include CAD with ischemia or infarction, cardiomyopathy, myocarditis, aortic stenosis, hypertension, mitral regurgitation, and then some metabolic disorders. And then we also have positive pressure, mechanical ventilation, and PEEP that can increase thoracic pressures and decrease venous return, which also decreases preload. So our high cardiac output states, so we have that septic shock, so it's related to that massive vasodilation and decreased peripheral resistance. That can increase our cardiac output 3 to 4 times what the normal amount is. And then we also have thiamine deficiencies, which cause vasodilation, and then increased metabolisms from things like thyroid toxicity, tremors, and increased oxygen consumption. So our SpO2 is the measurement of the balance between arterial O2 supply and O2 demand at the tissue level. And we get this by sampling desaturated mixed venous blood from the pulmonary arteries, which gives us our SpO2. So normal SpO2 is 75%. Critically ill range is 60 to 80. And then our patient compromise, there's a compromise if the SpO2 decreases by 10% or is less than 60%. So SpO2 monitoring is done to determine the adequacy of tissue oxygenation. It helps us to evaluate that balance between kind of supply and demand. So like oxygen supply and metabolic tissue demand. It's indicated for patients with an actual or potential for an imbalance between oxygen supply and metabolic tissue demand. It's going to include our patients with severe sepsis or septic shock, our post-high-risk cardiac surgery, so those CABGs, or our severe respiratory compromised patients, such as our ARDS patients. So oxygen is taken up in the lungs and then delivered to tissues by hemoglobin molecules in our blood. And then some of our PA catheters have the ability to monitor our continuous SpO2. I think St. Bernard's does, if I remember correctly, unless they've changed since I worked there. So the catheter basically uses a light emitting, like fiber optic type deal to help illuminate the blood in that pulmonary artery. And then another fiber optic receiver helps to absorb that reflected light. So the hemoglobin in the RBCs is what reflects the light according to its saturation. So then we have that SaO2 is the measure of saturation of hemoglobin in the arterial blood, and then SvO2 measures that saturation of hemoglobin in the blood when it returns to the heart after having passed through the body, tissues, and the cells. So we also have desaturated blood from that pulmonary artery catheter tip that is sampled for the SvO2 reading. And then we have 4 big factors that contribute to this balance. We've got cardiac output, so how much blood's being provided to the tissues and the cells. We've got hemoglobin, which obviously carries that oxygen in the blood. So is the patient's hemoglobin adequate? We have saturation of arterial blood with hemoglobin, so that SaO2, so how well are the patient's hemoglobins being saturated, and then tissue metabolism, so how much oxygen is the tissue consuming. So cardiac output, hemoglobin, and arterial oxygen saturation contribute to the supply of oxygen to the tissues. And then we have our tissue metabolism is what we term that VO2, and it's going to determine our oxygen consumption or quantity of oxygen extracted at the tissue level, creating the demand for oxygen. Mixed venous blood in the pulmonary artery is normally 65 to 77% saturated with O2, and this represents adequate tissue perfusion and oxygenation. An SvO2 of 60%, like I said a minute ago, 60% or a decrease of 10% or more indicates a compromise in at least one of the determinants of O2 delivery. A decrease in cardiac output is the most common issue. So complications of hemodynamic monitoring. So we can have, obviously, dysrhythmias. Anything sitting in the heart obviously isn't supposed to be there because we put it there. So it can cause arrhythmias, any kind of like CVL or PA catheters, things like that can all cause arrhythmias. And then we can get endocarditis. We can have valve damage, cardiac rupture. If one of those catheters punctures something, it can rupture things and cause a lot of damage. We can have tamponade. Our pulmonary artery can rupture if that PA catheter gets moved or dislodged. We can have pulmonary artery thrombosis, embolisms, or hemorrhage. Lung segment infarction. Because remember that picture where that PA catheter floats to. It sits in that pulmonary artery. So that pulmonary artery supplies the right lung, while the left pulmonary artery, on the other hand, is going to supply the left side of the lung. But we have that pulmonary artery catheter that sits in the right pulmonary artery. So we can have lung damage if it gets dislodged. And then obviously infection, because anything in the body that's not supposed to be there is obviously always an infection risk. Okay. So there is some controversy regarding like some PA catheter issues. So rates of use have declined in response to the lack of benefit demonstrated in clinical trials. It's definitely beneficial, and I think there are becoming more and more newer products that aren't as invasive that are starting to be utilized. And I think a lot of people are trying to show that the evidence, surrounding the PA catheters just it's not as beneficial as a lot of people think for some patients. So study on PA catheters in high-risk patients undergoing cardiac surgery showed no benefit on morbidity and mortality, but they were associated with longer length of stay in the ICU and an increased duration of mechanical ventilation. PA catheters in shock increased 30-day mortality with no improved outcomes. And then PACs are no longer used in the routine management of critically ill patients with shock. So studies have confirmed that no benefit, survival, or days in hospital from pulmonary artery catheters is any medical or surgical population of critically ill patients. So we very well may see these kind of phase out in the coming years, but I do know that the hospitals here local do still utilize them. But studies and research and evidence don't lie. So as I was saying, there's, becoming some more and more less invasive things. So this is a non-invasive, minimally invasive way to measure cardiac output. It's called a thoracic electrical bioimpedance, something like that. I've never personally used one of these, but basically it uses pulsatile changes in the thoracic blood volume, and it results in changes in the electrical impedance. So the rate of change of impedance during systole is measured and used to calculate cardiac output. It's really cool, and I definitely don't mind I have a video for you guys on it if you want to see it. I definitely don't mind to show it to you, but yeah. I've never used one of these, but it is kind of cool how things are becoming less and less invasive. So you may see one of these used if you go work somewhere in like a cardiac unit, especially at a bigger hospital or like a big research hospital. They very well probably do utilize these. So anyway, okay. Well, I know that was a lot, but we will talk on Monday, and we'll do a test review and some review games, and I hope you guys have a good weekend. If you need anything, just email me. I'll see you guys Monday.